AFib as a preventative, something we can prevent. So the AHA now includes lifestyle risk factor modification as one of 4 pillars in thinking about managing AFib, along with anticoagulation, rate control, rhythm control. And then I was privileged to be part of this NHLBI workshop that focused on, okay, what are the priorities for prevention of AFib, and we landed really on lifestyle factors. And I will touch a little bit on these now 2-year-old guidelines, even though it's 2023, they came out in 2024, which I also had the privilege of being a part of, especially on the lifestyle front. So I'll start with some studies from Prash Sanders, who's in Adelaide, Australia, who, as an example, published this very important trial where they took, the story goes that they had an extremely long waiting list for AFib ablations. Prash was originally known as really a proceduralist. And so it was like a year-long wait. And they were trying to figure out, okay, what can we do for these patients while they're waiting around for their ablation? And they developed this sort of infrastructure to help patients with weight loss. And they randomly assigned obese patients with atrial fibrillation to either undergo this formal program to help them lose weight versus just let them lead their lives, and demonstrated that, yes, the people randomly assigned to that program lost weight, and they also substantially reduced their burden of AFib. So this really provided the first evidence that not only was obesity associated with AFib, but this provides evidence that obesity causes or can certainly contribute to atrial fibrillation, and that managing weight may be a strategy to help mitigate it. The same group subsequently performed this randomized trial, focused more on physical activity, so demonstrating that even independent of weight loss, and even in those who aren't necessarily obese, random assignment to being more physically active can similarly reduce the amount of atrial fibrillation. I was asked to write an editorial and invited one of my colleagues who's a cardiac rehab expert, Alexis Beatty, and we tried to make 2 points. One, kind of a larger and longer term implication that we really need resources to support this sort of program. So right now, unfortunately, cardiac rehab is not covered for AFib alone as an indication. So Alexis and I was just telling Miguel, and some other colleagues are working on trying to get a study funded to demonstrate benefits of cardiac rehab specifically for AFib, in the hopes that CMS would then reimburse it, and then other insurance companies might follow suit. So one of the problems is, and this applies to all of this lifestyle stuff, we have a lot of information now, but we don't have a great way to actually implement lifestyle change, apart from just giving patients advice. So the other much more practical and immediate implication of these findings is that we can reassure our atrial fibrillation patients that it's not only okay to exercise, but actually they should exercise. So it's completely understandable that those with AFib, especially those with paroxysmal AFib, may be quite reticent to exercise for fear that they're out for a run and suddenly they go into AFib. And so I always tell my patients, listen to your body. If that happens and you're not feeling well, of course, slow down or stop. But don't let the concern that might happen get in the way of getting out there and exercising. Not only is exercise good for so many things, but it actually might reduce your risk for atrial fibrillation. There is this kind of complicated wrinkle when it comes to physical activity in AFib. I'm happy to get into that in the question and answer, which is to cut to the chase. There is good evidence that highly trained endurance athletes are at higher risk for AFib, which is probably a different kind of form of AFib. And interestingly, that evidence or that data has only been seen in men. It's never been seen in women, even in the same cohort. And there's a statistically significant interaction there for reasons that are not understood. But that's someone who is a professional cross-country skier, a professional cyclist, exercising 4 hours a day every single day. So we should not take that information to extrapolate to the general population, the great majority of whom would almost certainly benefit from more physical activity. So these have made their way into the new guidelines, where essentially, and there are specific numbers here which I worry a little bit about. It's, that it presents a target that may not be achievable or seems too specific. The point is that obese patients should be highly encouraged, and we should give them the resources they need to lose weight in order to help them reduce their AFib. And in general, the population should be more physically active to help address their atrial fibrillation. Okay, moving on to alcohol. So there have been many studies to look at this question of, well, does alcohol cause atrial fibrillation? This is one of many meta-analyses that generally conclude that yes, indeed, people who drink more alcohol tend to exhibit a higher risk of developing atrial fibrillation in the future. Now again, I chose those words quite carefully, deliberately. So in these studies, the great majority of the studies, the way they work is people are asked at some baseline state, how much alcohol do you drink? And then they're followed over time to see if they develop a new diagnosis of atrial fibrillation. And these are all observational studies, which we know are prone to confounding. Not only, we can adjust for covariates, but we have to know what those covariates are. And very often, we don't really understand what the confounding factors are. And even if we understand them, oftentimes they're incompletely measured. They're usually measured just at baseline. It's very rare, if not non-existent, to actually measure and accurately characterize these potential confounders over time. So we've tried to think about, okay, how can we address confounding in a different way? And also, these studies tend to rely on self-report of alcohol. Is there some way to get around that, where obviously there's potential stigma when it comes to alcohol consumption? So I'll talk about a few approaches that we've taken. One approach is to use something called an instrumental variable, or do an instrumental variable analysis. So an instrumental variable is something that, at least ostensibly, is associated with your predictor of interest, in this case alcohol, but as far as you can tell, not directly associated with the outcome except through the predictor. And so the idea is that if you can show a relationship between that instrumental variable and that outcome, maybe you can mitigate confounding. It's not magical and it's not as good as a randomized trial, but at the very least, I would say that if there's confounding, it's very different than conventional confounding. So it's a nice kind of complementary approach. And it just so happens one of the ways we did this was to utilize the great state of Texas, where, and this is a map based on the data that we used. We had data from every hospitalization in Texas between 2005 and 2010. And the counties in white here are counties that prohibited all alcohol sales. Those in black had no restriction on alcohol sales. And I can talk more about comparisons between those two, but for now I'll focus on what we thought was kind of the most valid and interesting counties, which are the crosshatched ones, which changed their alcohol access laws during the study. They all went from dry, prohibiting alcohol sales, to wet, allowing alcohol sales. And what we found just looking at those counties was when they converted from dry to wet, there were more codes for alcohol abuse or alcohol use disorders subsequently. There was more alcoholic liver disease, and there was more atrial fibrillation. So suggesting maybe a causal relationship on a population level. Another way we conducted such instrumental variable analysis was using these commercially available Bluetooth-enabled breathalyzers. So it turns out that a lot of people use these for their own purposes, and I was able to work with this company to get data from tens of thousands of people over several years, and we got all of their measurements as well as some demographic information. This was a publication where we applied a machine learning algorithm to demonstrate we could predict when someone's blood alcohol was going to be 0.08 or more. And then we used these data, and essentially we looked at all of the dates And we looked at, okay, are there certain dates or certain events during which people are more likely to use these devices? Almost certainly they're only using them if they've been drinking. And when the blood alcohol is greater than 0.08%. And then we combined all of those kind of recurring events. So these events are not things we just pulled out of the air because we thought maybe they'd be associated with drinking. They were empirically derived and showed or found that yes, indeed, on aggregate, those events are associated with more visits to ERs for AFib. And we did a negative control analysis where we looked at SVT. There's no evidence that alcohol increases the risk for SVT. Same ERs, no difference in SVT. Again, using an instrumental variable to demonstrate a potential causal relationship between alcohol and AFib. Now, a common question is, well, but if you're seeing someone in clinic, they've been drinking all their lives, is the cat out of the bag, or can you still meaningfully affect their risk for AFib? So we did this observational study using data from the ERIC cohort to demonstrate that those who stopped consuming alcohol, that used to consume alcohol, actually did experience a lower risk of atrial fibrillation. Subsequently, Alex Voskobojnik, who is from Melbourne, Australia, he was with us for a little bit as an EP fellow working with Peter Kissler, and did this very elegant study. This was Alex's PhD project, essentially, and he very generously has referred to the study I showed in the former slide as kind of an inspiration for this, where they took quite heavy drinkers who had AFib and randomly assigned them to either nothing, essentially just let them drink, versus trying to get them to quit drinking. And they showed that the group randomly assigned to abstinence exhibited a lower burden of AFib. So like with that first study with obesity, here is really the most compelling evidence that alcohol really does cause atrial fibrillation. Now, that does not mean that all atrial fibrillation is caused by alcohol. We know that because we see patients with atrial fibrillation without alcohol. There are also lots of people who drink. We see people with end-stage liver disease due to alcohol, and they don't have AFib. So it's one of many contributing factors to what is probably a final common pathway, that is atrial fibrillation. Now, all of these past studies generally are focused on chronic relationships. But the first description of this potential connection between alcohol and atrial fibrillation was really this idea of the holiday heart syndrome, this idea that exposure to alcohol acutely triggers a discrete episode of atrial fibrillation. But in the past, this was all kind of relying on, case series from emergency rooms where people said, oh yeah, I was drinking alcohol. And of course, there's a kind of an availability bias, and we see this a lot in our atrial fibrillation patients who are very often, understandably, curious about and thinking about their potential triggers, like why did I go into AFib at 4 o'clock on Tuesday, and that didn't happen on Wednesday, oh, it was I had that cantaloupe, it must have been the cantaloupe. So it can be hard to study these sort of real-time, temporally sensitive relationships. So we've tried to address this in a couple of ways. One was with to my knowledge, this is the only double-blind randomized trial of alcohol in at least cardiovascular medicine. So a group at Indiana University developed this pharmacokinetic model where they, using serial breathalyzers, could get a blood alcohol concentration up to a pre-specified amount and clamp it there. So we applied this in a double-blind way, an alcohol infusion versus a osmolality and volume matched infusion among patients undergoing AFib ablations. So one limitation, although as Miguel pointed out, perhaps a strength of the study was that these patients were all under general anesthesia. We had a protocol so that they could not receive anesthetics that had known EP effects. Perhaps that helped mitigate any related autonomic effects. And because we were doing AFib ablations, we had all these catheters in place. So we did a full, actually much more than full, a very comprehensive electrophysiologic assessment of their atria, looking at conduction velocities, looking at refractory periods, then they got the infusion, they had serial breathalyzers. The group randomly assigned a placebo, they had a script. So the operators didn't know what they were getting, and the coordinators would call out, oh, now it's 0.02, even though it was actually 0, so that no one knew who was getting the alcohol versus the placebo. And in short, and then during the infusion, so the group randomly assigned to alcohol, they were clamped at 0.08%. So it didn't matter how big they were, how fast or slow they metabolized alcohol. Everyone had the same amount of alcohol versus placebo. Then we repeated during that infusion that same comprehensive atrial electrophysiologic assessment, and we found that the group randomly assigned to the alcohol had a substantially shortened atrial effective refractory period just in the pulmonary veins. So we know from our ablation experience that the pulmonary veins appear to be extraordinarily important when it comes to both probably the initiation of and perhaps also the perpetuation of atrial fibrillation. So there's something about probably the pulmonary vein left atrial connection that's especially important. And we also know from animal studies, from computerized models, that shortening the refractory period tends to render atria more prone to fibrillate. Many of the antiarrhythmic drugs we give, such as amiodarone, Ticocin, they work by prolonging the atrial effective refractory period. And we did not see this in the placebo arm. So providing some mechanistic evidence that there really is something that happens quite acutely when exposed to at least high levels of alcohol that would appear to render the atria more prone to fibrillate. Now, to my great chagrin, we were unfortunately not able to demonstrate a difference in AFib inducibility. Why? We don't know. Maybe it's because it was too blunt of an instrument. The people were just super prone to going into AFib. They were all, AFib patients after all. Or maybe it was too acute. Maybe there's something that takes a little bit more time, because actually when we ask patients, when you have an AFib episode that you attribute to alcohol, how long after the alcohol does that usually take? They told us the median response was 4 hours. So it's not immediate. There are some people who have this seem to have this, a cold drink kind of immediate response where there's something about perhaps esophageal irritation, but most people describe several hours later. So we took those data and applied them to this ambulatory population of patients with paroxysmal AFib that drank sometimes, gave them a continuously recording alcohol sensor, and we put a UCSF cardiology sticker on it so they didn't have to worry about the stigma of wearing an alcohol sensor like that. Gave them a Zeo patch and found that yes, indeed, when exposed to alcohol, there was a heightened risk of a discrete AFib episode just within a few hours later, and it seemed to occur about 2 to 4 hours is when it sort of peaked. And then finally, we did this study, randomized trial, called the iStop AFib trial, where paroxysmal AFib patients could select their trigger that they wanted to test, and then they underwent their own N of 1 randomized trials where they were assigned to expose yourself to your trigger, avoid the trigger. They selected a bunch. Unfortunately, nothing came out in intention to treat, but in the as treated, the only pre-specified trigger that came out as associated with AFib was alcohol. And as a little bit of foreshadowing here, I will point out that those who selected caffeine did not have a positive relationship, and in fact may have had, if anything, there was a reduced risk of an AFib episode. So these data all together were used to help support this new guideline. Again, to my knowledge, this is the first kind of formal guideline related to alcohol use, apart from, of course, alcohol abuse or alcohol use disorder. This is just drinking in general, that patients with AFib seeking a rhythm control strategy should minimize or eliminate alcohol consumption to reduce AFib recurrence and burden. Now, a very common question is, well, what about just 1 drink per day? And what about primary prevention? And here, there's actually conflicting evidence. So these are the 2 studies that I'm aware of that were large enough to get at this. If there is a relationship, it's going to be very small when it comes to 1 drink per day. So on the left is from continental Europe, And they found that, yes, there was a statistically significantly higher risk of a eventual diagnosis of AFib among people who drank 1 drink per day, very, very small effect size. In contrast, from the UK Biobank, an even larger study, the people with the lowest risk of AFib consumed about a drink a day. And this tended to be people who consumed red wine. So conflicting evidence. So I recently served as the vice chair of this scientific statement from the AHA. So we were admonished time and time again as we're crafting this, and I've been involved in a few of these now, that this is a scientific statement, not a guideline. So our charge was to review and report the evidence. What is the latest and greatest evidence on this subject? Not to give recommendations, although reporters can't seem to disentangle that and seem convinced that we were seeking to make recommendations, although I understand those can be easily conflated. And kind of the central figure of this is here. And this has become a little bit of a sticking point for me, and it's been very interesting to deal with the political side of this, not politics like Democrat, Republican, but essentially these kind of fixed beliefs that are not based in science or evidence, where there's this pendulum swing with alcohol, where yes, probably there was too much positive press about alcohol is good for the heart. But in my view, and as someone that has published, as I've shown you, evidence of harms of alcohol, the pendulum has swung way too far the other way, where now there's this zeitgeist that, well, all alcohol is toxic, there's no healthy amount of alcohol, all that data on protective effects of moderate alcohol consumption, that's all wrong, we now know better. And just to cut to the chase on that, that is not true. We do not know better. The studies that fail to show a protective effect are not superior to many of the studies that have suggested a protective effect. All of these are observational. They're all weak evidence-wise. But we have to report and go by the available evidence. So just to review that briefly. So even when it comes to blood pressure, there's randomized trial evidence of no difference, although the observational evidence suggests that more than a drink, probably a drink, does seem to be associated with higher blood pressure. Now, on the other hand, with the exception of AFib, where I've shared some of the randomized trials, this is really all based on observational evidence, again, clearly prone to confounding. But if we're honest about it, so first of all, greater than 2 drinks per day, or probably 2 drinks really on an occasion, increases the risk for pretty much any cardiovascular outcome you're interested in, including MI. So that, the one place where the evidence is strongest that maybe there's a protective effect is arguably coronary disease, MI. But excessive drinking more than 2 drinks, increases that risk. There's really no controversy there. The data is very, very consistent. The questions and the conflicting evidence really has to do with drinking in moderation, so about a drink a day, really. And if we have an honest review of that evidence, again, limited by observational study designs, the evidence is that in coronary disease, the risk is either no different or reduced. Stroke, the risk is reduced. AFib, I showed you, it's mixed. Sudden death, the risk is reduced. Heart failure, the risk is reduced or no difference. These are the data. And some people will say, well, but Mendelian randomization studies show that drinking in moderation is associated with a higher risk or actually doesn't protect against anything. Mendelian randomization studies, and I'll give you an example in a few slides, are, again, they're an instrumental variable analysis. They are useful, but they are not randomized trials. And there's a bunch of potential really important limitations of them I'm happy to get into if folks would like. But more importantly, they're much better at teasing out those who drink heavily versus not. There is no gene for drinking in moderation. There are studies that have derived the genetic variants associated with moderate alcohol consumption by just looking to see, well, what are the genetic variants of those who drink in moderation, and then let's look at those genetic variants as a predictor. But that's arguably prone to the same confounding because you're relying on the self-report of the behaviors of the individuals in the first place. So as I mentioned, there's this growing idea that, and this is from the World Health Organization, there's no level of alcohol consumption is safe for our health. So where is that coming from? Just to steelman that position. They base it on this Lancet study from the Global Burden of Disease, published in 2018, where the conclusions were our results show that the safest level of drinking is none. So just to dive into this study, like what did this study actually show? And I apologize, this is not super easy to see. In brief, so these curves, so this sort of linear curve is seen for breast cancer. So for breast cancer, there does seem to be a heightened risk even for moderate alcohol consumption from observational data. But you'll notice these curves are kind of J-shaped, meaning lowest risk not among the abstainers at the far left, and I'm sorry, I think there we go. So these guys are kind of J-shaped, this one and this one. So these are diabetes and coronary disease. And this is the paper where they said there's no healthy amount of alcohol. So it's not that clear cut. Interestingly, there was a update from the Global Burden of Disease in the Lancet where they try to get at this, well, maybe there's some positive effects, maybe there's some negative effects. And this is what they found when they try to combine all outcomes. The lowest risk was actually among moderate drinkers, or people who drank once in a while or in low amounts. So what did the WHO do in response to this update from the same group in the same journal? So this is my slide for crickets. Just to show, I think that there's for some reason, there seems to be some bias on their end. And again, I recognize this can come across as me being very, pro-alcohol. Not at all. I'm pro-research on the subject, and I think we need randomized trials. And one of the challenges is, and I've already encountered this, that if you want to study moderate alcohol consumption, if there is this baseline assumption that, well, all alcohol, we already know that all alcohol is toxic. The IRB won't approve your study, the NIH won't fund your study, and patients won't participate. I've dealt with each of those already, that I've been told by the IRB, well, you can't, we've had to kind of dance around and change language, like we can't say drink alcohol, we have to say, okay, today don't abstain, which is obviously quite clunky. And the NIH has